Settle in. This is Unintended Consequences, episode 36. It's June 21st, 2026. Every story we cover starts with someone who had a reasonable plan. In 2002, a nurse at a Pittsburgh hospital rubbed alcohol based gel into her hands between patients. She followed a new CDC guideline meant to replace time consuming soap and water scrubs. Within a decade, the same product sat in hallway dispensers across American offices and schools. People used it dozens of times a day, even if they never entered a patient room. The measure that lowered hospital infection rates now sits at the center of a quieter debate: whether routine, non clinical use is helping bacteria adapt in ways that matter beyond the ward. The push began inside hospitals facing stubborn rates of methicillin-resistant Staphylococcus aureus and other healthcare-associated infections. Infection control teams knew that hands were the main vector, yet sinks were often inconvenient. Compliance with traditional hand washing hovered below 50% in many wards. Alcohol-based hand rubs offered a faster alternative that required no water. They dried in seconds. They showed strong activity against gram-positive and gram-negative bacteria in laboratory tests. The World Health Organization's 2005 Clean Care is Safer Care program and the CDC's 2002 Hand Hygiene Guideline both presented these rubs as a practical, evidence-supported tool for busy clinicians. At the time, the dominant concern was immediate patient safety rather than long-term ecological effects on microbial populations outside medical facilities. Hospitals installed wall-mounted dispensers and trained staff with visual audits and feedback. Compliance rose sharply in many centers. By 2009, the WHO had published a global hand hygiene guideline that explicitly recommended alcohol-based formulations as the standard of care when hands were not visibly soiled. Early data from Geneva University hospitals and other sites showed reductions in certain bloodstream infections and Clostridium difficile rates. The same convenience that worked inside hospitals appealed to schools and workplaces during flu seasons. By the mid-2010s, pump bottles appeared beside office coffee machines and classroom doors. Few regulatory barriers existed for consumer products, so adoption spread faster than formal surveillance of non-clinical use. Once alcohol rubs moved beyond the hospital, the volume of use increased dramatically. During the first year of the COVID-19 pandemic, U.S. sales of hand sanitizer rose more than 600%, according to retail tracking data. Many workplaces kept dispensers stocked indefinitely. Laboratory studies have since shown that certain strains of Enterococcus faeum can develop modest increases in alcohol tolerance after repeated low-level exposure, though the concentrations used in clinical products remain effective. The larger concern lies in indirect effects. Frequent disruption of the skin microbiome may alter colonization resistance. This potentially allows more resistant organisms to persist on hands that then travel into communities. Wastewater sampling in several cities during 2020 to 2022 detected elevated alcohol residues near schools and offices. This raises questions about whether environmental bacteria encountered sublethal doses capable of selecting for cross-tolerance to other antimicrobials. Because alcohol resistance is not tracked the way antibiotic resistance is, the scale of any contribution remains difficult to quantify. Yet the causal pathway from high-frequency application outside controlled settings to possible shifts in microbial ecology is now under active study. Public health agencies have not withdrawn recommendations for healthcare settings. There, the benefit-risk balance remains favorable. The FDA's 2016 ban on triclosan and other antibacterial agents in consumer soaps addressed a different mechanism. This left alcohol products largely unaffected. Some infection control researchers now advocate judicious use messaging for healthy community settings. They emphasize soap and water when feasible, but no coordinated reversal has occurred. Long-term epidemiological studies that could link sanitizer volume to population-level resistance patterns are still underway. Current guidelines continue to treat the community risk as plausible but not yet actionable. When an intervention succeeds inside a narrow, high stakes environment, its diffusion into everyday life can change the underlying conditions that made it safe in the first place. Monitoring systems designed for one context rarely capture second order effects that emerge only after widespread adoption. The practical question for any new hygiene or antimicrobial technology is therefore not only whether it works where first deployed, but whether its routine use elsewhere can be measured before cumulative exposure becomes difficult to unwind. Consider a new surface coating now being tested for public transit that kills microbes on contact. If it performs well in hospitals, what early signals would you watch for once it appears on every subway pole? And that's where today's story leaves us. If it changed how you see one everyday decision, that's the whole point. Pass it along to someone who'd appreciate it, and we'll be back tomorrow with another case. And before you go, this show is part of the NARA Network, a family of daily podcasts covering tech, science, markets, and more. If you enjoyed today's episode, give Models and Agents a listen, your daily briefing on AI models and agents. You can explore the whole lineup at neuranetwork.com. This episode used AI voice synthesis of my voice. Editorial selection and analysis are my own.